Welcome, everybody. This is an introduction to short-term psychodynamic psychotherapies. The aims then are going to be to provide a summary of some foundational core competencies for those of you who are less familiar with the intensive short-term dynamic psychotherapy model, or ISTDP, to help you get more familiar with some of the key issues around the broader family of short-term psychodynamic psychotherapy therapies. So our objectives then are going to be to help develop some key knowledge and skills so you can start to get more familiar with the broader STPP model. For those of you who are more familiar with STPPs and the intensive short-term dynamic psychotherapy model, then this will hopefully be more of a refresher for you. So a good place to start then is just distinguishing between some general psychotherapeutic competencies which we need across psychotherapy models, and then some more basic and specific dynamic therapy competencies, which we're going to be looking at in this lecture and the course. So general psychotherapy competencies really apply across psychotherapy models, and I won't go through all these. You can see them here and look yourself through the slides, but some key issues like being able to understand broadly how we conceptualize mental health problems, how you're going to start to engage a client in a treatment-based process, how you're going to manage endings in a psychotherapy contract, and even as much as how you're going to use supervision to be able to broaden your skills and to um, develop and provide effective psychotherapy. And when we think about psychodynamic competencies and those which we're going to be looking at in this course, whilst we're not going to cover all of these key competencies, we're going to cover some of these. The ones we're going to really emphasize then are the key principles around a dynamic approach. We're going to think about how you start to engage a client in a dynamic therapy approach, how you start to formulate or conceptualize the patient's presenting issues from a psychodynamic frame, and then how you can start to get the ball rolling with interventions for setting the treatment frame and maintaining the treatment frame. A couple of metaphors then to help you think about the dynamic model more broadly. It's quite different from other psychotherapy models, which most people are trained in graduate school. It's psychotherapy models which are more problem-based in terms of and instructional, in terms of teaching patients key skills and being more directive in that. Dynamic therapy is more implicit and relies more on implicit skill learning during the treatment process. And one way of thinking about this is the concept of there being macro processes within therapy and more micro processes, which we narrow in on understanding a therapeutic process. And we can think about needing to be able to narrow in on specific processes. So we really study the trees and narrow in on understanding specific processes which are occurring, but also being aware that those trees are occurring in the context of a broader forest. So we always want to be tr balancing that sort of fine line between narrowing in and not missing the woods for the trees, but also vice versa, not getting so caught in on the minute detail that we lose the bigger picture. Another metaphor is paralleling dynamic therapy to a game of chess. So the similarities here are that the typical ways you start a game of chess, there are only a few ways in which you're going to do so. And the same for dynamic therapy. You're typically clear on how you're going to get the ball rolling. Likewise, in chess, you know how the game's going to end. Um, Similarly, in dynamic therapy, you have a sense of how the process is going to close. But the intervening moves and processes can't be spelt out. In that sense, it isn't a clearly manualized process where there's a clear direction. So it really involves the therapist to tolerate uncertainty and being able to work really with the process and what's happening in front of you and letting the process unfold without trying to control it too much. So the first core competency then, which we're going to talk about is basic knowledge and principles around the rationale for a psychodynamic or dynamic therapy. And we're going to talk a bit about the importance of personality development, thinking about object relations theory, attachment theory, and the role of emotions in the dynamic therapy model. So some of the key assumptions then in dynamic therapy are the first around the importance of unconscious or implicit behavior. Uh, this idea here is that a lot of what patients and individuals and ourselves are generally aware of in terms of our behavior and what motivates and elicits our behavior, we're largely less aware of those. And that it's particularly often the implicit or unconscious factors which can we want to narrow in on in therapy and help the client narrow in on to better understand perhaps why they're experiencing the difficulties and patterns and symptoms they are in life. The importance of transference and this idea of the ubiquity of transference, the idea that we all naturally transfer over templates of past relationships onto current relationships. And this is fundamental for influencing how we think and behave in relationships and our perceptions and experiences of relationships. So, in that sense, we want to narrow in on really think about transference and understand transference for helping a person understanding why they experience life the way they experience. And the third key point here is that dynamic therapy is very much a developmental model. So this posits that the early developmental relationships are very key for how we end up experiencing difficulties later in life and psychopathological difficulties we have, and also the way in which our brain and personality shapes as a result. And this is not to say that our early experiences necessarily cause the difficulties we have later, but through understanding the importance of early relationships for shaping and impacting how life unfolds for us and how we experience the world, this can be a key tool in dynamic therapy. So, dynamic therapy ultimately can be seen of as a way of understanding human behavior more broadly. And in doing so, we want to think about the role of personality. Uh, Personality really being a window for understanding how we experience the world and how we therefore relate to our environment. This emphasizes the importance of our internal working model, which relates to ourself and other people. And this idea that at different developmental stages through our life, we develop, we have key experiences which shape the way in which we view ourselves and we view other people. And this is particularly important when we think about the developmental experiences with early caregivers. And in dynamic therapy, we really emphasize the impact that these early attachment relationships have and the messages that the child internalizes from the caregiver that shape how we begin to understand the world. And these self structures and other structures in terms of understanding the self and understanding other people that become internalized in these early relationships can represent a blueprint or a working model for how we end up establishing and then maintaining future relationships. So, in brief, we develop mental representations of ourselves and of others or objects, and these become key building blocks for then how we experience and interact with the world. And these are going to develop early in infancy, and they also interact with more genetically derived factors, including temperament. But these representations of self and other are heavily influenced by our internalized experiences from our attachment relationships. And the memories of these experiences become templates for what to expect in future relationships. But importantly, later internalizations, i.e., the messages we get from later relationships around how we should feel about ourselves and feel about other people, they can actually modify these internal structures which are laid down earlier in life. So that's critical. It means there's malleability in these structures. But also theoretically, it's important to remember that these psychological structures are ingrained patterns which they're slow to form, so they develop gradually over our life, and therefore they're also going to be slow to change. And critically, that these processes and structures are not directly available to consciousness. So we have to work to help a patient understand these and for us to understand those ourselves. And typically, there are some key themes which characterize the working model that people develop to understand the world. So if we can start to narrow in on these themes, then we can start to help a person become more aware of their own working models. So theoretically, then, why do we actually construct internal working models, and how are they adaptive in terms of informing and guiding our future relational behavior? Well, this is where we can start to pull on attachment theory, and it ties over with the object relational theory we just discussed. So if we think about the importance of attachment and well-being, Bowlby introduced the concept of it being an evolutionary need to have an innate desire for closeness with a primary caregiver. And it's basically this early relationship and the ability to get um, for our attachment needs to be responded to in a sensitive and caring and timely manner, which help us develop a sense of well-being. So this idea of consistency in our early relationships and a sensitivity to the needs we have from our primary caregivers are key in informing our social and emotional development. And they particularly give rise then to what we can consider attachment patterns, or these internal working models that help us predict um, how other people are going to respond to our needs in the future, and therefore elicit thoughts and feelings and behaviors in later relationships. So then when we experience adversity through the developmental trajectory, what's critical here is that we experience a consistent, sensitive, and responsive caregivers who respond to our needs and our attachment needs to help us actually effectively regulate our stress around the adversity. But through attachment theory, we can begin to presume or hypothesize that insecure attachments begin to develop when, as a consequence of adversity and primary caregivers or attachment objects, not being able to sensitively respond to our needs in the way that is required from the child and infant or adolescent even. And the learning, the implicit and explicit learning that happens here around that our attachment needs are not going to be responded to in an attuned, sensitive manner, which can lead in insecure attachment relationships to more the dysregulation of emotional experiences. So then if we think about the role of uh, object relations for thinking about the way in which we develop these working models of self and other. And then we take attachment theory to help us understand the importance of having attachment experiences which are positive to help us regulate stress and to expect positive adaptive responses from people around us. What we can then assume is then the emotions which again then are going to get triggered in relation to our attachment needs are actually going to be extremely significant in terms of informing our behavior. So the more we can listen to emotions which get triggered and bodily activations regarding emotions, it's going to help us make sense of our world and listen to the degree to which our attachment needs are likely going to get met in different relationships. But the problem becomes here when this emotional compass, if you will, i.e., the compass which helps us think about where we are, so how are we doing in life and relationships, how do we want our relationships to be, and how do we want people to treat us, and how are we actually going to get there? Well, a challenge becomes is when we're not able to listen to these emotions. So valuable information around how to form adaptive, caring relationships is lost when our emotions become infused with anxiety and we start avoiding listening to our emotions by defense mechanisms. So what happens then here is instead of listening to our emotions about attachment needs being met or not met, in fact, what happens is anxiety comes in, and then our actions in relationships are driven more by anxiety and defenses and not our emotions about getting attachment needs met or not met. So in therapy, then we can think about the fundamental role of emotions being if we can help patients begin to understand, face, and express and be aware of their emotions around their attachment needs and help them tolerate the anxiety which comes when they start to explore attachment needs and adversity around attachment relationships which have gone less well in their life to actually begin to inform more adaptive future behavior. And particularly through helping a person cope with and listen to and understand and make sense of their emotions around attachment needs. This can help activate these internal working models and begin to transform and change behaviors related to what was once maladaptive internal models to more adaptive models, which include listening to emotions, not just fleeing from emotions. So here's a quick case example to help you conceptualize this. So I'll read this through and you can do the same. So a man then in his early 50s, having a lot of difficulties at work because he was frequently ending up in disagreements with his colleagues. And his position in itself required that he worked with his colleagues as a troubleshooter. So it's crucial he could actually relate to interpersonally to colleagues and get on with colleagues. However, we could understand that the reasons he was getting to so many difficulties is unconsciously he was superimposing onto these work relationships an old family pattern in which he experienced his needs being ignored by his parents, who he perceived as favoring his siblings. So instead, here he was perceiving his colleagues as dismissing his needs. So as a result, at work, his challenge then became to either experience the feelings which are coming up inside of him regarding this theme around his needs being ignored or perceiving that his needs were being ignored. But in fact, what we could assume would happen for this person is that instead of being able to feel his emotions about the perceived feeling unsupported, um, instead, what he ended up doing here is um, he started to relate to avoid his feelings and in fact start feeling dissatisfied at work, feeling unhappy, low mood, irritability. And whenever his emotions would get triggered up inside him about perceiving people as unsupporting him and not listening to him, he'd quickly become anxious about these feelings and expect criticism from those around him, which could manifest as social anxiety and would often experience panic-related symptoms, which would guard and shut down awareness of the actual feelings which he was having about feeling unsupported. Such it creates this vicious cycle of behavior where feelings are going avoided, and in fact, he's in this vicious cycle of getting anxious and depressed at work. So then if we have these core principles around why we start to focus in on relationships and attachment themes in particular, next we're going to start to think about how do you start to establish the therapeutic frame. So how do you get the ball rolling in therapy? This is going to overlap with a lot of broad psychotherapy modalities in terms of how you begin treatment. We're always going to want to make some explicit arrangements for the treatment itself. Um, we're going to want to structure the interview through listening to the patient's problems and the difficulties which they're wanting to look at. And we're wanting to model and convey the role that we're going to play in potentially helping the client. And it's going to be critical to develop a therapeutic alliance, so a relationship of trust and developing rapport in the therapeutic endeavor. And one of the key elements to this in dynamic therapy is going to be formulating the basis for the problems a person experiences in interpersonal relationships um, and understanding the symptoms that they experience as a consequence or related to relational experiences. Slides are a bit off here. I'll just skip through these. Um, so how do we actually begin to explain the treatment process? And in dynamic therapy, we can say the process is more implicit rather than explicit compared to some treatment modalities. So when we get the ball started, the ball rolling at the beginning of treatment, then what we might do is we might say something like, I'm going to listen very carefully to what you have to say, and that we can work together towards achieving the changes that you'd like to make. And that might be as far as you actually go in terms of explaining what you're going to do. Rather, the emphasis in dynamic therapy is going to help a person learn about the process through doing rather than telling. So we're going to demonstrate a collaborative process through how we are with the person rather than necessarily telling them that that's what we're going to be doing. It does require, though, that we actually begin to elicit some goals. So often one of the early things we'll do in dynamic therapy is we'll orientate a client to saying, tell me about the actual problems which bring you here. You know, what brings you to see me? Presumably there are some difficulties or challenges you're experiencing in life that make you want to be here today and you want us to look at. So the goals are important in dynamic therapy as with any other therapy in that because they can become the goal or markers of whether or not you're making progress in treatment. They help us think about actually what the patient is wanting to achieve and what we think we can actually achieve in therapy. But they can also bring a lot of urgency and purpose to the therapy through being very task and goal focused. How do we establish the working relationship in dynamic therapy? Well, much like other broad therapies, but one broad principle we can think about is demonstrating that we're going to be a reliable figure for this person, that we want to help and that we feel as though we can help. We're going to help to establish boundaries for the treatment, and we're going to focus the boundaries of therapy around the goals that they want to work on. And we're going to hold those boundaries through the course of therapy. Keeping in mind that, like in any therapy, we can get too drawn into looking at the importance of technique, and this can often get in the way of alliance in itself and be problematic. So it's always a balance between maintaining an alliance and developing an alliance and using specific techniques within a specific modality to help make the process effective. So what are some of the explicits around arrangements for treatment? Well, these are often things that you typically address at the end of your first session. That's typically what I'd recommend somebody would do. And these can involve the typical length of sessions, if the person's paying out of pocket, if it's being covered through insurance, or if it's through the public healthcare. You'll need to just discuss these pieces. How are you going to handle missed sessions? When you're going to meet, ideally, you're going to have a consistent time you meet each week, and roughly the length of treatment. So, and whether it's going to be open-ended treatment or time-limited treatment, so you can begin to judge around whether the goals of treatment have been met or not. So when you're thinking about the length of treatment, people often ask, with it being called short-term psychodynamic therapy, like what exactly does that mean and how long actually is treatment? Well, it's worth keeping in mind that the concept of short-term was really relative to the historical recommendation within psychoanalysis for repeated sessions each week with a 5-year duration for psychoanalysis proper. So the evolution of short-term model, different interventions to offer a relatively briefer treatment course. Typically, we're talking about less than 40 sessions when we think about research and how we categorize short-term therapies, but treatment can be much shorter than that too. One of the key principles behind short-term dynamic therapy is the attitude which we have around time management. So we're always looking to use time as effective as we possibly can. And part of the way we do this is we as a therapist, and we encourage the patient to have a clear focus on the relevant issues at any given point. And we always want to remain very, very conscious and alert to factors which interrupt or get in the way of having a collaborative focus on the goals which a person comes into treatment for. Also, within short-term model, you can have more time-limited or you can have open-ended therapy. So you might specify that it's going to be a 10 session or a 20 session treatment. Or you might say that we're going to have it open-ended, but typically the expectation is that you wrap up within 40 sessions for the the average presentation. Um, Again, this is going to vary depending upon the goals that you're looking at, whether you're looking at for symptom relief or more personality and character change, but also the presentation that the client actually comes in with. So we've taken a bit of a look at how you're actually going to begin to broadly get the process started explicitly. Um, Now we're going to think a little bit about how you start to engage them in dynamic therapy in the initial session. How do we start to think about dynamic principles and use those? So first and foremost, how do we start to understand and respond to the problems which a patient describes? Well, we have two broad aims, we could say. We want to listen carefully to the difficulties a patient describes, and we want to, both for the client and for ourselves, to begin to construct an image or a picture of the difficulties which they're experiencing, the functioning that they have in day-to-day life. And through that, we then want to start to generate a series of questions or hypotheses around why this situation exists. So what's our theory around why they're experiencing these difficulties? Then we're going to have various techniques to help us begin to work with these. So the first can be a phenomenological approach to survey a person's difficulties and symptoms. So we want to base the focus of our session on their description of the difficulties they actually come in with. Then technically, we want to start to take a listening stance, but also be actively inquiring to try and establish the specific details around the relational context in which their symptoms or difficulties manifest. And typically, we see that there are one or two key themes, interpersonal themes, or attachment themes, we're going to call them, which relate to the difficulties which a person presents with. And then we're going to structure therapy around these attachment themes. And once we can understand these key themes or attachment themes, we're going to use these then to explore a person's emotional world or the feelings which get triggered inside of them when these attachment needs are activated in life. So what does dynamic inquiry look like? Um, well, first we want to establish some specific examples. Um, so we want to be asking the client to give us specific instances based upon the difficulties which they have, which have an interpersonal context to help us begin to talk about these and develop an understanding of the working model or the way in which a person experiences the world. And this dynamic inquiry, it's going to involve a reflective dialogue with ourselves and the client, where we listen to what they say and we reflect back what they say to understand the themes which manifest. We always want to adopt a curious stance. So we want to listen to both what the patient is saying, but how and why they're saying what they're saying. When we see differences or ambiguity around what they're saying and how they're saying it, we want to query those. Um, and ultimately, we want to help a person understand and make sense of the uncertainty and hostility they experience day to day, and in even understanding themselves. Now, broadly speaking, this process of inquiry, we can see it as a common sense approach, in that what we're looking to do is help a person understand the thoughts and feelings they have, but also help them see the way in which these impact the difficulties they experience, and to help them reflect upon those and ultimately look to make changes in that through generating probing questions which help them begin to question why they think the way they think and how that impacts the types of difficulties they might be having. And we're always wanting to track and understand the patient's response to what we're doing in session. So we can think about the idea of intervention response. So dynamic inquiry in a way constitutes a form of pressure to help a person understand themselves and to make sense of themselves and understand their emotions. And one way we can think about this is that as we start to narrow in and understand a person's world and help them do that themselves, that this in itself is going to be anxiety provoking. So we expect if we focus in on the conflicts they have in life, discomfort is going to manifest, and this can be important to share with the patient and use this to guide us. We want to help a person reflect and self-reflect upon these processes. And we want to help a person begin to trust in us as we engage in this process. So here's a list of, potential areas that you might have in mind when you're inquiring around a patient's difficulties. And I'm not going to read through these, but these are more just for you to have in your back pocket of different areas that you could organize the interview towards examining in terms of beginning to elicit some of these relational examples when symptoms might manifest. And the key thing to say here is that there isn't a specific order in which you look at these, and you might not necessarily look at all of these. They're just themes that you can have in mind that might help you better collaboratively to understand some of the themes a patient experiences in their life. So then the next competency we're gonna talk about here is how do we begin to derive the dynamic formulation, and specifically we're going to talk about the triangle of conflict and the triangle of person, and also the concept of an attachment theme. So our formulation really is our working model for therapy. It's what constitutes our structure that the client and ourselves use, and we use in supervision for thinking about how we organize the therapy and what we're doing and why. It becomes our way of understanding the problems a person has, to formulate the goals and how change is going to come about, and to help to anticipate difficulties or obstacles which might manifest in the treatment process itself. The triangle of conflict here helps us understand a person's intrapsychic world, specifically around the importance of feelings and impulses related to our feelings, connected to relational experiences, which can manifest anxiety when these feelings are coming towards consciousness and we're actually beginning to have to think about how we feel about our relational needs being met or not met. This is anxiety provoking, particularly if in our early life we've had negative relational experiences in which we didn't develop a secure attachment and these feelings were tolerated. So as a result, when emotions start to manifest now and become more cognitively aware of our feelings, we start to experience anxiety. Then we can start to think we're either left with our anxiety or we have unconscious defense mechanisms which help to reduce anxiety about feelings through also warding off or pushing out of consciousness our awareness of the nature of those feelings and the attachment consequences. And the intrapsychic world always occurs in an interpersonal sphere. So through this, we can understand, through what we've covered already with our psychodynamic theory, the importance of past relationships, shaping the internal working model and the feelings that can be triggered based upon our past relational experiences can then play out in current relationships. And therefore, we'd also expect the same to manifest in the therapeutic relationship or the transference relationship. So through using the two triangles, the triangle of conflict and the triangle of person, we can begin to formulate and understand the ways in which feelings, unconscious anxiety, and unconscious defense manifest in the past, therefore in a person's current life, and therefore also play out in the therapy room. However, in order to begin to start to formulate and work with the triangle of conflict and triangle of person, one concept I've introduced to my own work and my own teaching is this idea of an attachment theme. So what I mean by this is that if we look across short-term psychodynamic models, there's a common tendency to develop a a narrative which helps to describe relational experiences which are predictable patterns of interpersonal experiences and behavior. Often we can see that there's one or two key themes or key stories which are organizing interpersonal themes which help us understand the types of difficulties a person experiences in life. And this is structured around ultimately their early attachment relationships. So these themes provide a coherence to the narrative they've had in terms of their life history. And typically, we'd expect that they'll help us understand the nature of the difficulties and symptoms and when they actually begin to manifest. So, through beginning to develop and understand an attachment theme, what often is a more unconscious or implicit impact on a person's life, these can actually start to manifest into more predictable behaviors, which a person begin to understand why they experience difficulties when they do, and in which contexts that they actually begin to do so. And likewise for the therapist, then we can start to ourselves begin to organize and understand why a person has the difficulties they do. So in this way, we're using our dynamic theory to say that past events shape or represent a blueprint for understanding repetitive interpersonal behaviors which play out in the current life and also manifest in the therapeutic relationship. So we can think about the attachment theme then as an underlying theme which is ultimately going to help us understand the unconscious pattern that a person plays out in certain relationships or situations. And it always represents a plausible narrative. It makes sense to the client and to us, and it typically incorporates the key components of a person's current relationships, but also the impact of past relationships. And through understanding the two, it includes a description of the problems and the nature of the problems that a person comes into therapy for, and therefore the goals in therapy, the things that a person is wanting to change. And then it can serve as a guide then for the types of interventions we're going to use in therapy, i.e. what we do at any given time. And we can also therefore understand the types of relational patterns that are likely going to play out in the therapeutic relationship through understanding the patterns which occur in a person's current relationship and stem from past relationships. So in doing so, we can begin to look at is therapy on track or not through looking at the degree to which a person is beginning to step out of these patterns which typically play out in their life. And it becomes a key organizing feature of the therapeutic relationship and the collaborative relationship through establishing attachment themes and looking at emotions related to attachment themes. So then just a reminder around the basis, the theoretical basis for the attachment theme and why we think these are important. Our assumption here is that the patient's current manifesting difficulties are in part related to templates of past relationships, which influence how they experience current relationships and their perceptions in current relationships. And the impact of the unconscious or implicit motivations, attachment relationships, which impact our behavior, and how interactions with current people and current relationships and those in the transference can activate these old emotions about attachment needs, and these lead to emerging maladaptive patterns. And in doing so, we can think about how it's the repetition of emotions triggering these repetitive behaviors which are really a compromise solution to try and avoid feelings which are emerging. And we avoid them through repeatedly engaging in these maladaptive behaviors. But it's these maladaptive behaviors and cycles which in self perpetuate the problems a person has. So if we can start to help them understand the patterns and become more aware of the patterns, there's a greater possibility they can begin to exert more control over their emotions. So what are the key components of the attachment theme then? Well, the first key aspect is a statement of the person's central wish or the needs they have across relationships. Then the second key aspect is a consequence or a statement of the consequence when a person tries to get their attachment needs or attachment wishes met from other people. So the attachment wish can be thought of as what a patient or a person wants from an interaction or from a person, how they're hoping to be treated, how they're hoping the person's going to respond to them. So you might ask questions like, what did you want the person to say or do? How did you want them to respond to you at specific times? It's also important to to remember that the attachment wish specifically is meant to guide uh, appropriate or adaptive adult behavior rather than more aggressive or maladaptive behavior. So an example of this would be if you're asking a person around situations in which they became potentially more depressed or more anxious, the person might start to tell you about they noticed that when they were at work, they got felt more self-critical, and their mood dropped in the days following a specific interaction with their boss. And you start to say, well, tell me about that interaction. And you might start to draw out. So how were you hoping your boss was going to respond to you in that situation? Um, and they might say, well, I was, presenting and describing some ideas I had, and I guess I was hoping that they might listen to what my ideas were. Okay, so there was something important about being listened to. Tell me more about what you were hoping that your boss might say or do. I guess I was hoping that they would listen and maybe they would, accept that my sort of perspective was valuable and, was important. Um, So through in doing this, you might begin to get the impression that part of the person's attachment wish here is about acceptance and being heard uh, in a relationship. Or it might be that when you start to talk about relational contexts, which are important to this person and where they start to have difficulties or they experience distress, you hear themes such as the desire to be loved and understood by other people. Again, the critical piece here around distinguishing adaptive attachment wishes from more unhealthy or destructive wishes. So, at times when you're drawing out how you're hoping a person, um, what they would want or what they're hoping another person might respond or how they might be with them, they might come up with something. Well, they were hoping that the person would just leave them alone, that they wouldn't bother them. Uh, or they were hoping that they might say that they wanted to react and retaliate against somebody. Well, often these are more defensive reactions or unhealthy and negative ways in which a person responds to a need going unmet. So in these cases, what we're wanting to reorientate a person towards a more adaptive desire or hope for how the person might be, and distinguish this from uh, the reaction that they might have or the fantasy they might have around what they would do or what the person might actually have done towards them. So then when we start to look at the second part of the attachment theme, we're thinking about the consequences. So in doing so, we're thinking about the expectation or the actual response from the other person when a person has an attachment need. So we're looking at how does the person actually react, or how did the person fantasize that the person might react? And again, it can be either anticipated what they expect a person would say or do, or it can be the actual experience of what the person did. What's critical, though, is that it's not totally hypothetical. It involves a person that there was an actual instance where they had an interaction or they fantasized about an interaction. And then you're looking to elicit then the response of the other. And it could be more helpful or it could be more negative. So in doing so, then we've got an attachment wish, how they're hoping to be treated, and we have an expectation or actual response or a perception of how the person did actually treat them. So when we're looking to elicit these relationship examples, often some of the key things to have in mind is we're looking for times in which there was conflict between what a client or a person hopes for or wishes for in a relationship, but what they actually experienced. And it's fine to actually write down these examples that you elicit in session if that helps you initially to organize your own thinking and to keep these in mind. And as it gets a little bit more fluent and comfortable for you, it gets easier to hold these in mind, but it's fine to write these down if you need to. And what you'll typically see that after you review multiple relationship examples, that you start to hear and see common or overarching themes emerging. Um, and often what we'll see is that it's these key themes which underlie the situations when they're presenting problems actually emerge. So in theory, what we're assuming is that there are one or two key themes which represent repetitive interpersonal concerns across relationships, which are likely going to underlie the difficulties which a person comes into therapy for. So if we can start to draw out and identify these attachment themes, um, then these can be how we start to organize our early part of treatment. And we orientate clients to listening for and talking about examples where they had these attachment needs and they had these expectations or experiences. And once we start to narrow in on a key theme, we can then use this to start to invite a person's feelings about the degree to which those needs were met or not met. Um, so we might have an example where a client, you pull out a wish to be listened to and cared for, and they describe multiple examples, such as one with a partner, where what they experience or what they expect is to be dismissed and rejected. At which point you might say, I wonder what emotions get triggered in you towards your partner when they rejected you by doing X, Y, Z. So at which point this becomes our organizing structure for then beginning to examine feelings and the degree to which a person can sit with and understand their feelings and process feelings, or the degree to which they start to get anxious or they have avoidant defense mechanisms. So this becomes how we organize our early part of treatment to begin to examine the degree to which avoided feelings, unconscious anxiety, and unconscious defenses might manifest as presenting problems. So, how does the patient actually react internally and externally to the person when they perceive attachment needs going unmet? So we can use our attachment theme then to start to now examine the triangle of conflict and examine that moment to moment in session through inviting awareness of feelings, somatic experience of emotions, and where possible, expression of those feelings, and seeing to what extent in session we actually see manifesting anxiety showing when feelings begin to emerge, and to what degree we actually see manifesting unconscious defenses in session. And then we relate the same process to what actually happens in their life, whether the same process plays out when attachment needs are getting triggered. So when listening and identifying the relationship examples to do the attachment theme and to ultimately be able to start to work within the triangle of conflict and triangle of person, just some key considerations to have in mind. Some clients find it more difficult than others to spontaneously describe relationship examples. So at which point you can just prompt them towards recent exchanges with people which left them dissatisfied or unhappy. Or it can be eliciting times where the actual symptoms or problems that they have began to emerge and search for a relational context that way. One thing to have in mind here is that uh, the actual interactions that you're looking at, they do need to be real or at least imagined. They're not totally hypothetical. And keeping in mind again that the response in which a client has the consequence for emotions being triggered, it's a subjective perspective or experience of how the other person treated them or they perceive they were going to treat them. Okay, so this in this lecture here, the goal primarily was to begin to summarize a few key competencies to help orientate you towards the short-term psychodynamic psychotherapy frame. So we've looked at some key bits of knowledge and basic principles around the STPP frame, how you can start to establish a therapeutic frame, engaging a patient in short-term psychodynamic therapy using specific techniques, and how you can start to derive a formulation to begin to organize what the treatment's going to look like and where we're going to focus in treatment. So hopefully this was helpful for you, and I look forward to seeing you in the lecture.